AHPI, as many of you know, represent the collective voice of healthcare providers across the country, working to improve quality, safety, and accessibility in healthcare. We are pleased to present this session with the kind support of Farmed, our partner, and we thank them for partnering with us in this initiative. This is the second webinar in this series of tendinopathies. All of us know that this is one of the most common conditions we encounter in daily orthopedic practice. The first session was a great success. It focused on general tendinopathies, and today's program builds on that momentum. We are very privileged to have with us three internationally known speakers, very eminent orthopedic surgeons, and an expert moderator who will take us to the different dimensions of tendinopathy around the shoulder, an important part of practice, both for medical management, rehabilitation, and to the surgical perspectives. With that, I now request Santosh, Dr. Santosh, a moderator, a very eminent orthopedic surgeon focusing on sports medicine at the Bangalore Baptist Hospital, to take the webinar forward. We'll have a brief lamplighting ceremony, after which I request Santosh to take over. Over to you, Arvind, for the lamplighting.
Good evening, one and all. I'm Dr. Santosh from Bangalore Baptist Hospital. I welcome you all for today's webinar titled as Strength, Function and Recovery, Modern Perspectives on Shoulder Tendinopathy. As Alexa was speaking, it's a very common problem you encounter in day-to-day practice. So it's very common, but still diagnosis and management continue to be always create some discussions, general discussions, because right from clinical diagnosis, right through imaging, what we need to image, what needs to be done as first stage, what needs to be done second stage. It's all it's not straight cut, clear cut as in other most of the other conditions which we encounter in our day-to-day practice. So enlighten about this, we have this webinar, and we are very privileged to have such a senior faculty as Alexa mentioned. And first speaker I'll like to introduce is Dr. Vinu Cherian, who is the who is so Dr. Vinu Matthew Cherian, he's a HOD of Believers Church Medical College Hospital in Tiruvalla. So he'll be guiding us on assessment of the shoulder tendinopathy, medical management, and what is the pathogenesis. And he will definitely, with his clinical knowledge and the experience he has, will definitely able to enlighten us more. Second speaker is Dr. Naresh Shetty, who is now heading the Akash Institute of Medical Sciences Research. He is all well known for bringing the Ramaya Medical College Hospital to its present status. So he will be guiding us on the rehab plan on the shoulder tendinopathies and what are the basics of rehab and how do you go about rehab. So he'll be guiding us on that. And final speaker is Dr. Krishna Subramaniam, sir, who is also a very senior consultant, and he's heading the Department of Sports Medicine in Yashoda Medical Hospital in Hyderabad. So he'll be guiding us on what are the indications of surgery, when do you want to operate, and what are the surgeries involved in shoulder tendinopathy. And I hope you all are keep yourself engaged. And I want you all to put forth your questions in the question and answer box, chat box, and we will try to answer as many as possible on them. And now I I'll hand Vinu Cherry, sir, so to start the webinar. Vinu, sir, it's up to you, sir.
Thank you. Thank you, Dr. Alex, Dr. Santosh, for the words of encouragement. Greetings, um, my senior colleagues, friends. Uh, so I'll be dealing mostly in the medical management of tendinopathy. So as we all heard, it's a very common problem. It is not just restricted to the sports people. This dysfunction affects the general population, especially the senior citizens also. So um, for me, I think I will take you to the basic tendon biology, and Cook and Purdom has introduced this term of continuum model of tendinopathy. Then, um, what is the evidence on non-surgical or medical treatment, and what are the recent advances, and how can we apply this algorithm to our day-to-day practice? So, basically speaking, the tendon has got muscle tendon region, then the tendon proper, and the insertion. And tendon has got two types of cells. It's called tenocytes and tenoblasts, and mostly made of type 1 collagen bundles, and it has got an extracellular matrix. The tenocytes are the ones who are recently really the cells of the tendon. So they can proliferate, they can produce collagen, and have produced enough extracellular matrix. There is something particular about its blood supply. There are no blood vessels within the bundles. Outside the bundles and within the connective tissue, these blood supply. And these blood vessels are mainly arising from the muscles itself. Okay. And they receive the nutrition by diffusion. There are no blood vessels directly in the tendon. So as you look at the nerves, again, the nerves are mainly the supply from the muscles. And these are also involved in the regulation of the blood flow within the tendon, and they also release some trophic factors, which we'll deal it at a later time. Uh, so now we go. What is the tendinopathy cycle? So tendinopathy cycle, as we all know, it is broken down into three. So first is the reactive tendinopathy, where an initial insult causes a tendinopathy, and then as we all know, usually the tissues repair itself, but in the case of tendon, it doesn't repair like that. So it is a uh, stage of disrepair. That's the second stage, but there is a matrix breakdown, and the most important thing is the neovascularization. There was a time when, based on cadaveric studies, people thought there is a watershed area in the tendons. Okay, I'm not denying that there's a watershed area, especially tendons like supraspinatus. But when later during surgery and during we're dealing with arthroscopic studies or tissues recovered from these healthy individuals, they found that there is a stage of neovascularization. So first is tendinopathy, then disease repair, and finally, if it's not dealt properly, the natural history is that it progresses to the next level, that is the degenerative tendinopathy, and where the irreversible collagen disorganization happens. So it was a type 1 collagen to start with, and finally we end up with a type 3 collagen, which is said to be more elastic, but it doesn't have that kind of strength in it. So again, one more slide showing the normal tendon. So in acute phase, it goes to reactive tendinopathy, then a stage of disrepair. So once it goes to the degenerative tendinopathy, it's very difficult to uh, get the proper recovery. So that's the basics about the continuum model of the tendon model. This is by the further meant. So again, what are the things, what are the different changes, morphologic changes happening in the tendon during all these three stages? The reactive tendinopathy, so we specify that is a non-inflammatory reaction, which is being attributed to a degenerative condition. So then the stage of tendon disrepair. So that is where the neovascularization starts. And if you are trying to recover the tendon or recover the tendon function, this is the stage where we should be intervening. And once it goes into degenerative tendinopathy, finally the ruptures and we may not be able to recover the function for the tendon. So again, this is a picture which denotes if you look at the last picture, that is where the neovascularization happens. And we will very soon see how we can manipulate this neovascularization to our benefit. So this is again basically how the breakdown happens. Sorry, the substance P and matrix metalloproteases are produced, which is released, which produces degeneration of the extracellular matrix, and neovascularization happens, and nerve endings are exposed, which produces or which is the patient experiences as pain. Okay, so what happens in the purpose of the neovascularization? Whenever the neovascular or angiogenesis happens, it is for usually for the repair or the tissues. So in a neovascularization, what happens? It brings more blood supply into the field. It helps in synthesis of collagen and extracellular matrix. So it should be leading towards the uh, repair of the tendon. But what happens that along with that, there can be increased secretion of the substance P and MMPase, the matrix metalloproteinases, which is again producing more and more, or upregulation of MMPase produces more and more breakdown of the extracellular matrix and the degeneration of the tendon. So what is the flip side? So we think that normally neovascularization or angiogenesis produces repair of the tendon. But here what can happen is the other side, the flip side is if the blood flow is not proper, that angiogenesis is not proper, it increases pain, it enhances the MMPase upregulation happens. So finally you can end up with collagen and matrix degradation, and finally the tendon may be at a stage of no recovery. And these blood vessels may not be the proper functioning blood vessels. So that is the flip side of the neovascularization. So how can we manipulate this stage of neovascularization or the angiogenesis? Okay, we can use it as a target for increasing the blood flow and vasodilatation, so that it brings more oxygen, nutrients to the tendon. So which will help in fact, rather than apoptosis of the tenocytes, it will help the tenocytes to proliferate, produce more collagen, type 1 collagen. So this can be in a way can we manipulate by some way, by some um, uh, medical management to use the neovascularization to our benefit. Let's see. So this is one more slide. I would like to go to the next one. So this is to illustrate how tendon degeneration happens in advanced tendinopathy. So as disease advances, so decreased oxygenation happens, and this decreased oxygenation finally lead to apoptosis of the tenocyte or tenocyte that happens. Then this will lead to decreased collagen synthesis, and uh, so degenerative mediators like substance P or MMPase will come into action. So collagen breakdown, extracellular matrix breakdown will happen. So finally, the tendon will go into the third stage, that is the okay. So that is the tendon degradation. That's how it happens. This is what the proposed theory. So decrease tenocytes finally, and decrease in collagen 1. So attempted repair either happens by the collagen 3 or just fibrosis. And finally, it can end up with massive ruptures. So this one, again, we have seen the same thing. So it will lead to advanced tendinopathy. So this is one thing which I have to show the thing. So if you look at the orange colored diagram on the outside, how can we utilize the neovascularization to our benefit? That means new blood vessels is coming, so increased blood flow, it brings increased oxygen, increased nutrients, increase building blocks to the site, and which will, in fact, encourage the tenocyte to produce, proliferate, and produce uh, uh, increased collagen synthesis, and which can be for our benefit. But in the meantime, if the vascular endothelial growth factor also gets activated, it can produce a more substance P or MMPAs, and finally it can end up with a collagen and matrix breakdown, and finally lead to enhanced tendon degeneration. So this can be what we are looking at, is whether this stage of neovascularization, that is in the stage 2 and the stage 3, can we manipulate it and can we use it for our advantage. So pathogenesis is, we have already seen, a failed repair happens. So then there is, what is happening is biochemical, biomechanical, and cellular changes are happening. So death of tenocyte, and then loss of matrix, and biochemical mediators like growth factors, neuropeptide cytokines are also released. So if you look at the clinical staging, the acute symptom is from 0 to 6 weeks. This is an arbitrary classification. Subacute is from 6 to 12 weeks, and chronic is usually more than 3 months. This is I would like to say this is an arbitrary classification, but we can use it. And most of the time, patients present to us maybe by 3 months after this initial treatment by a GP or somebody. So this already we have seen that as the neovascularization advances, the tendon is going into the advanced degeneration stage. So what is the traditional management? As we all see, our impression is any tendinopathy or any tendinitis is inflammatory disease. So everybody starts with, and when the general practitioner starts with non-steroidal anti-inflammatory agents or painkiller, and the usual practice is to supplement them with an oral steroids to reduce the inflammation. But as our understanding is, this is not an inflammatory disease, it's more of a degeneration. So the traditional medication management is modify, give them rest, ice, and analgesics, and corticosteroid injections or corticosteroids. But how far does it help? Okay, so the available treatment, we know that this is not enough. So we know right now, we know that is a multimodality management. So these are the modalities available to us: NSAIDs, anti-inflammatory enzymes to reduce the swelling, oral steroids, steroid injection, and physical therapy, and splinting, and extracorporeal ultrafiltration. So what is the benefit? If you look at the things, no, meaning uh, uh, none of these things are giving us any long-term benefits, or maybe a short-term benefit. Okay, so we know the limitations of the standard or the routine NSAID treatment or the steroid treatment, because at any time we are not getting uh, long-term benefit, or we are not they are not helping us with the tendon regeneration or to preserve the tendon. That's what actually we want it. We don't want it to go from stage 1 to stage 2, or then advance from stage 2 to stage 3. So can we prevent that progression of the disease? So none of the available, the current treatment is, or the standard treatment is not able to do that. That is why when we are looking at whether can we stop the degeneration or can we at least do some regeneration. So I would like to bring your attention to what are the recent advances, what are the agents available to us. So we have a platelet-rich plasma. There are different types, either leukocyte-rich, leukocyte-poor, or even pure platelet-rich plasma. So as I understand, uh, the leukocyte-poor PRP is the one which we would like to use. Meaning, along with the PRP, the platelet growth factors, vascular endothelial growth factors, transforming growth factor beta, insulin-like growth factor, these are all the active agents which are brought in. So again, this is a mini intervention. The PRP is supposed to be given into the tendon degeneration, the area of degeneration, and it has to be given there specifically. And that it has to be repeated 3 to 5 ml every 2 to 4 weeks for 3 or even up to 5 injections. So that is the picture about PRP in the recent. So this is a diagram which explains how the PRP acts. So whenever we give this is with Velasquez Gracia about his um, uh, idea about or explanation or thesis about how the PRP acts. So if you look at that, okay, it can act in the inflammatory phase, the proliferative phase, and the remodeling phase. It can help in the regeneration. And what we get on the clinical side is an improvement in the function and improvement in the pain relief. So if you give it appropriately and at the appropriate stage, it is beneficial. If you look at the simple regenerative approach, it has limitations in advanced diseases. So what is the role of one of the other agents called L-arginine? Arginine is an amino acid. It is a precursor of nitric oxide. So if when it is given in a low dose and when the nitrous NO synthetase, nitric oxide synthetase acts on it, it is converted to nitric oxide, which again helps in neovascularization. So a low dose sustained release L-arginine, suppose we give, is given orally, it is helpful. It is a precursor of nitric oxide. It's helpful in causing vasodilatation, neovascularization. Again, improves the blood flow, brings more oxygen. It again helps in tenocyte proliferation, matrix formation, and so on. So nitric oxide is beneficial. So what is the role of oral collagen supplementation? Is it placebo? Is it science behind it? Is it evidence-based? Low molecular weight collagen, when given in adequate dose for adequate duration, it is seen that these collagen get hydrolyzed and it provides building blocks, that is proline, hydroxyproline, and all that building blocks for the regeneration of the collagen 1. Okay, so this is again, this has been shown in studies. So what is it is dosage? When I search the literature, it's a varied dose. The daily dosage was recommended. Some studies recommended 5 grams per day. Some studies recommended even up to 15 grams per day as oral dose. And this has to be combined with vitamin C. I will come into the role of what is the role of vitamin C in the medical management. And there are studies which have shown that if it's given for adequate time, that is 3 months or more than 3 months, if you give supplement low molecular weight collagen, it is beneficial. So we have a prospective randomized control study from AIIMS Delhi, which was conducted by the physical medicine department, where they compared the effectiveness of the low molecular weight collagen along with sodium hyaluronate and chondroitin sulfate and vitamin C on one hand, and on the other side is a diclofenac sodium. So they look.
Excuse me, you'll try and wrap up in 2 minutes. I think.
Sir, yes, sir. Thank you. Sir.
Thank you.
So they evaluate the parameters like they looked at this is from they did for the Achilles tendinopathy. They did a ultrasound. They looked at the pain score and quality of life SF36. So they have seen that in all the three there is improvement. There are other studies also showing that a combination of low molecular weight collagen along with sodium hyaluronate along with chondroitin sulfate and vitamin C is beneficial. Is there evidence? Yes, there is evidence. There are some other clinical studies also. So collagen peptides are shown to improve the tendon structure and reduce pain. It has to be combined with physiotherapy. So, but we still have to have robust, well-designed RCTs. Okay, so this is supposed to be the proposed way how the collagen measure. So when you are doing a mechanical loading of the tissues, so it releases growth factors. So dietary intake of collagen, it gives glycine, proline, and hydroxyproline, which is taken into the rough endoplasmic reticulum, and we get packets of the vesicles. They support the procollagen synthesis happens, and when this procollagen is taken back into extracellular matrix and get converted to type 1 collagen, this is supposed to be the way it acts. So there is evidence. This is from Gregory Shaw et al., American Nutrition. Both these are most of these studies are coming in the published in the nutrition articles. So vitamin C enriched collagen is giving good results. So again, there is this is from amino acid published by Harper et al. Strong evidence. Again, they suggest that it should be 5 to 15 grams. So again, they found that it's rather than young individuals, it is sarcopenic, the senior citizens, they found a better the body composition. Again, it has to be in along with exercise and along with vitamin C it should be. And muscle recovery has a modest, but again, significant improvement with collagen. So recent advances, again, injectable type 1 collagen, collagen scaffold, all can be used during surgeries. So there is emerging evidence, but we require more RCTs and robust evidence. Stem cell therapies are under research. Shockwave therapy and nitric oxide patches are also useful, and novel molecular, but stem cell therapy is also being looked at. So in conclusion, tendinopathy is a failed healing and it's not inflammation. And our aim of treatment is not symptom relief, but to have a regeneration of the tendon, or at least to preserve the tendons. And it is being shown that little dysplasma and collagen are promising, and there is evidence to show that there is functional recovery. And physiotherapy and load management, eccentric exercise are also essential for the treatment of these conditions. Thank you.
Thank you, Dr. Vinu, for your detailed presentation of your pathogenesis, the physiology of the tendon, pathogenesis, as well as the medical management. It was really extensive, like studying the physiology and pathology books. It's very good. Thank you, sir. Now we move on to the next talk, which definitely is a cornerstone of any tendinopathy treatment, the rehabilitation. I now request Dr. Naresh, sir, to take over and give us a valuable input on rehab.
Can you are we okay? Seen?
Yes, sir. Can start the presentation, sir. It's in a
presentation mode, sir.
perfect, sir.
All right. Okay, so after a detailed discussion, which Dr. Cherian did talk about the various problems that we have, I think we will come to one of the most important aspect is rehabilitation. We all know that the definition of a shoulder tendinopathy has been well described, and most of the time it is a degenerative. And the biomechanics has already been informed to us. But what has been the major area of concern has been the pain and the functional limitations. These are two areas which concerns most of our patients across the world. And so all of us know the shoulder joint is one of the most unstable joint, simply because of the large head and a small glenoid. But it has also given the maximum amount of movement possible compared to any other joint. And so what also we must remember that the most important stabilizer, the dynamic stabilizer for the shoulders are the muscles. And we need to protect as much as possible or strengthen them. And if you want to ensure that we have a beautiful return of function. So I think if you go into the management in terms of rehab, first effort would be to reduce the pain. Second effort is to improve the strength. Third is ensure functional rehab. And fourth is return to sports, because this is one of the common players that they usually get injured in shoulder issues. What is the purpose of this program? It's to help us in post-injury or post-surgery. And we will have the post-surgery discussion later on. But I think finally, the idea is to return to daily activities, enjoy a more active, healthy lifestyle, and also will help us in return to sports activities or normal lifestyle. So two things that we must remember. What are the two things? One is the strength. Second is the flexibility. And for the strength, we need to ensure that the muscle that supports the joint needs to be strengthened as much as possible, because they're the dynamic stabilizer of the joint. And keep this muscle strong can only relieve shoulder pain and prevent further injuries. Flexibility, stretching the muscle through strength is more important. Ensure gentle stretching and strengthening exercise usually reduces the muscle soreness and helps you regain function early. So what are the muscle group that are normally included in this program? Are the deltoid, trapezius, triceps, subscapularis, biceps, teres major, and supraspinatus. Before doing any kind of conditioning exercises, I think it's very important, before we get started, is to do a warm-up. And the warm-up normally should be about 5 to 10 minutes with low impact activities. Could be anything, but low impact. And after that, we should start with the stretching exercises before moving on to the strengthening exercises. And also remember that once you have completed the strengthening exercises, we must repeat the stretching exercise to end the program. For heaven's sake, let us not forget the most important part, pain. If at all you feel pain during these exercises, then I think it's important that we inform the doctor or the therapist at all. It is so very important that if a person has got a lot of severe pain, he will stop doing the activities, and probably we will end up going back to where we all started. So what are the principles of rehabilitation? Number one is pain-guided loading. Some discomfort is acceptable, but any sharp worsening pain is not acceptable. We gradually increase the resistance and the function reward as the patient is able to bear the load. We need to ensure postural and scapular control is done, for it's essential for long-term recovery. Always avoid complete rest. This rest part of it actually is dangerous, especially in terms of shoulder. And it control activity promotes tendon healing much better. We must also address some of the other contributing factors like the cervical spine, thoracic, or its biomechanics. What should be the length of the program? Normally, I would advise that we should have it at least for 4 to 6 weeks, unless otherwise specified by the doctor or the physiotherapist. But you must remember, after this recovery period of 4 to 6 weeks, the exercise need to be continued as a maintenance program for a lifelong protection and health of your shoulders. Performing these exercises on a regular basis will help in maintaining strength and range of motion in our shoulders. In a way, if you look at shoulder, it's one of the most grateful joints ever possible. It's one joint where you can almost tell the patient that he will recover 100%, not like the knees or otherwise, where you are expecting certain amount of restriction. But if it in shoulder, it is not so, and thankfully so, because of the fact that the joint being shallow. AOS has come with a lot of shoulder rotator cuff and shoulder rehabilitation exercises just to ensure people do it right. And so a normal shoulder rehabilitation program goes through 4 phases. Phase 1 is pain relief and load management, which is normally for 1 to 3 weeks. We ensure there is an activity modification, which is to avoid overhead or heavy lifting activities. Pain relief, isometric, scapular setting, and postural correction would be the things that are done in the first 1 to 3 weeks. The second week is basically for strengthening and mobility. Here is the time where we ensure that the patient increases his movement as well as improves his strength. So things like pendulum exercises, active assisted flexion, external rotation exercise are done. TheraBand could be used in many a kind of activities, and controlled lowering in external rotation or scapulation is probably possible. But it is very important that the patient understands what are the exercise that is done and how much could he do. One of the limiting factors would be the pain, and that should be always kept in mind. And many times I do tell my patient that please warm the joint by giving a hot packs prior and subsequently after the exercises. They feel it much better. The role of NASID in exercise therapy, I think it's very important that the patient does not have pain so that his cooperation to do exercises are much better than otherwise. So I normally advise the patient to take some painkillers for a couple of days till he's very comfortable, and then he goes ahead with does the exercise. The phase 3 is the functional strength and endurance exercises, usually for 6 to 12 weeks, and where we increase the load with either dumbbells, we do a kinetic change, push-ups, progressing knee and regular push-ups, and of course, low load rotators and scapular exercise. Basically, the idea is to improve on what all the gains that you had in the first 6 weeks. And the last but not the least, most important, I normally advocate that everyone must go to their normal sport or work. If at all we are not able to do that, then we have not completed our job. And that is something that we must always look at it. And shoulder is one place where I normally think it will come, maybe a little more time, a little less time, but it will come. Unless there's an indication for surgery where appropriate action need to be taken. For in the phase 4, we have overhead stability drills, medicine ball, wall throws, overhead carries, plyometrics, ball drop, push-up class, sport-specific retraining exercises. And we are in an era where probably we can assess the strength of each of these muscle and probably look at, say, a fast bowler requires a certain muscles. We can actually measure it and say, what is it and how much strength we need to do with that particular muscle. So we are getting into more and more specific when it comes to exercise therapy. These are some of the exercises that have been talked and spoken at AAOS, and anyone can get it across, whether it's pendulum, crossover, struck, or whether and other exercises that are possible. From regular rehabilitation to a regular one is what we are all looking at. And one of the things that has happened is how do we actually educate our patients to do the exercises when they are not with a physiotherapist? And most of them, often than not, once the initial acute phase is over, the patient tend to slacken down and not do the exercises, and hence he does not get the true benefit of what he should be getting it. And here, I guess, the format has come with a rehab exercise program, which anyone can download it, and you can send it to your patient the appropriate exercises that are required. So now it becomes easier for you to send by WhatsApp or by email to the patient and said, these are the exercises you continue. Once he comes to you, you talk to him, tell him these are the exercises he should do, and these are the exercises he should not do. There are quite a few exercises that are there available for the joint, whether it's for isometric or exercises and otherwise. But I think it's a good way of ensuring that the patient knows what is to be done. He can get into this particular link and the exercise. More important, it also gets the patients as well as the doctors saying these are the things that he should do and these are the things he should not do. So I think this is a very important benefit. I think people across should start downloading it for their patient. And patient is also happy that something is given to him. So patient-doctor relationship probably will be much better than otherwise. This is a link which is there. That is available here. You just have to go there, and it shows doctors advise you to follow this mentioned in the TendoCare rehab exercise. So the patient definitely knows what he has to do and what he doesn't need to do. Once we finish the initial rehab, what are the other things that are available now? Adjunctive therapies. My previous colleague, Dr. Vinod, did talk about some of therapies like steroid injection, PRP injection, shockwave therapy, and otherwise. Okay. I think all of us know few benefit, lot of people do not benefit, and lot of people have a chronic problems in despite all that we have done. But I think we need to go through step 1, step 2, step 3, unless we have a definite indications for a surgery. So what are the red flags and when do we reassess? Persistent night pain despite rehab. We need to relook at this patient. Revise if at all. There is no problem in looking at this the whole thing again and seeing that whether we have gone wrong somewhere. Significant weakness or pseudoparalysis. You must suspect rotator cuff tear. No improvement after 12 weeks of structured rehab. I think we need to probably investigate and then tell the patient what next to be done. So in conclusion, I believe an early structured rehab will give you the best outcome. And I again insist and persist when I say shoulder is one of the most grateful joints among all the joint possible because you can't get so much function as much as any other joint. But patient adherence is the key. He does it, he will get it. Multidisciplinary approach, both the doctor and the physio need to re-educate, educate, and again tell them how important it is for to tell them that a structured rehab is very good. I do believe that some analgesic can be given to this patient at least in the initial period so that they do their exercise better. I think I finished with my talk, so I'll stop sharing it. We go to the next.
Thank you, sir. Thanks a lot. So, as sir highlighted the need for rehab, which is the cornerstone of therapy, and also sir highlighted the longer duration which is needed. It's not that you do a rehab for 1 or 2 weeks and you should get better. Patient should have patience, and I think the physios and the surgeons are going to be important in telling them that. And sometimes with all this, you will not be able to treat them fully, and then comes the role of surgery. And I now request Krishna sir to guide us to what are the surgical options available in these modalities. Thank you, sir.
Good evening, Dr. Alex, Dr. Santosh, and all seniors. And thanks, Farmed and Dr. Alex, for having me in this webinar platform. I sincerely thank for giving me the opportunity to share my thoughts on the surgical management of the shoulder tendinopathies. Yes. Yes. As we all know that Dr. Vinu has very clearly mentioned, very nicely mentioned that any injury, maybe intrinsic injury to the tendon of the shoulder or any extrinsic factors like a bony factors, they can result in a reactive tendinopathy and finally resulting in a rupture of the tendon. Therefore, the surgical goals in these kind of situations are to remove the degenerative tissue because they cannot heal. And we try to stimulate the heal or the repair of the native tendon And we can use an open technique, an arthroscopic technique, or minimally invasive technique, depending upon the site and the position of this one. And before ruling out, before going to the surgery, we need to rule out certain problems, like we need to rule out both the local as well as systemic inflammatory causes and other local causes like cervical spine, etc. So now coming to what are the indications for surgical management of shoulder tendinopathies. As Dr. Naresh clearly mentioned, if they are not responding to a well-done physical therapy for a minimum of 6 months of conservative and physiotherapeutic management, and if there is associated functional impairment causing disability and activity limitation of the daily activities, and there is a radiological correlation or musculoskeletal correlation by evidence of structural degeneration like a rupture or anything, and especially it comes to the athlete versus non-athlete, we need to, the decision making should be always balanced in athletes patients. Then, as I told you, you need to look into all the local causes, starting from the biceps tendon, then subacromial area, and if there is associated instability, especially elderly, it is associated with cuff overload and cuff injuries too. And then scapular dyskinesias and associated trauma. X-ray may be showing quite normal radiological radiograph of the shoulder joint, or but we may miss on the CT scan or in the MRI. It may be clearly seen that there may be a footprint contusion which may be causing an injury to the footprint of the supraspinatus tendon. Then intrinsic degeneration, calcific tendinopathy, a sudden onset of pain, overnight pain in a middle-aged person, maybe we need to look into calcific tendinopathy and all these things. Now coming to each one aspect, the common one is a rotator cuff calcific tendinopathy. It is nothing but the hydroxyapatite deposition, and it causes immense pain with restriction to the motion of the joint, acute onset of the pain and night race. And that in this particular picture, I'm able to clearly show that this kind of calcific tendinopathy at the supraspinatus attachment. So what are the various surgical options? It's a OP procedure, or it can be sometimes an arthroscopic procedure. Ultrasound guided needling is a minimally invasive and outpatient procedure. And we need to continuously irrigate a saline or anesthetic lavage to break and aspirate the calcium deposits. And sometimes we may have to combine with a steroid injection, but it's only useful in the early and non-dense calcifications. But in dense calcification, sometimes you need to go for arthroscopic calcific debridement, and it is a gold standard in refractory cases where you can directly visualize the area of the calcification of the tendon and where to remove the calcific material. Sometimes while doing so, the underlying tendon may get damaged, or it may be resulting in a partial or subtotal tear where you need to repair the tendon to the footprint. Then comes the second variety, the common one, the anatomical variations of the acromion itself. The type 1 does not have any kind of symptoms. Whereas in type 2, and more so in hook type, that is type 3, where the subacromial space starts coming down, and any kind of altered biomechanics, they cause a repetitive trauma to the supraspinatus tendon, and that results over a period of time, tendinopathy, and sometimes that initiates a cascade of the irreparability resulting in a tear itself. And if there is under MRI or on ultrasound, if we do not find a tear in the tendon, and if we find a type 3 acromion, especially with the acromion spur, that needs to be reshaped, the underside of the acromion. Usually it is done very rarely, but it has to be done to widen the subacromial space, and sometimes it may involve bursectomy and ligament release also, that is coracoacromial ligament, which is sometimes. And this is a video where an isolated subacromial decompression is being done, and acromioplasty. We can use a burr through the lateral portal. The viewing portal is from the posterior one, and that's how we can do. You were able to see very clearly the hook type of acromion and the anterior aspect, and that's how Once you do the burr, then the raw surface of the undersurface acromion can be ablated by RF ablation so that the pain also come down. And we can extend the same thing if there is associated AC joint arthritis also. The undersurface of the projecting clavicle also needs to be resected as needed. And this is another case where malunited greater tuberosity fractures. The first one is initially is missed, and finally that results in improper healing of the fracture with a displacement causing subacromial impingement and also altered biomechanics. And that may cause a biomechanical consequences, and that results in impingement risk and the development of tendinopathy. And finally, the function of the shoulder may be impacted very badly because of the altered biomechanics and impingement too. In such cases, we need to do the various surgical options depending upon the amount of the displacement and the amount of the bone piece and amount of the impingement. That is like osteotomy and repositioning if the patient is present in subacute, or an open reduction and internal fixation properly, especially when it's malunited or ununited, and also associated with instability. Then arthroscopic subacromial decompression if the displacement is minimal and malunited. And if the associated cuff tear, we need to do the cuff repair and also decompression. Then we need to do excision arthroplasty, especially at severely displaced, comminuted small fragments and not reconstructable. Then tuberosity excision can be done and the footprint repair need to be done. And finally, if the chronic severe dysfunctional arthropathy and failed previous surgery, we may have to go for a shoulder arthroplasty. These are the points, if there is necessary, we may need to consider based on the patient indications. Then come the partial cuff tears and stiffness. It's a very unusual. Initial, as Dr. Naresh sir is clearly mentioned, when it is early and the patient misses the use of physiotherapy, that may result in stiffness because of initially that is going towards periarthritis shoulder. Stage 1, stage 2 can be managed with some kind of physical therapy guided by the physiotherapist as advised with the NSAIDs. But if it is going for stage 3 and 4, where the stiffness increases, the best option could be a distension hydrodilatation, which is a very minimally invasive day care procedure. And that is how we do. I do it routinely in a under fluoroscopy. First inject the dye, identify the glenohumeral joint, then inject saline up to 80 ml to 100 ml very slowly. And you can see in the last picture how the joint got distended. And take, with the help, when the your assistant is stabilizing the shoulder, take the joint in the complete arc of movement very gently, no manipulation in this. So patient gets complete range of movement because already it got distended, and you can see, and then inject the dye into the subacromial space post-distension to know the cuff integrity. And that's how a distension hydrodilatation can help in a partial tears with the stiffness and resulting adhesive capsulitis. Then comes to, if the tendinopathy continues and degeneration continues, that may result in a frank tear. And the tear, depending upon the need, we need to do a arthroscopic repair. For example, in this case, you can see a degenerative tear progressed, finally a massive cuff tear. There are multiple repair techniques like a single row repair, if the tear is a minimal one or a partial one. The double row repair, if the footprint needs tendon to bone compression and with the eventual proper fixation need to be done. And then in the double row, again, there are a lot of configurations. There's a classic double row repair, or a suture bridge technique, or a knotless trans-osseous equivalent, that is speed bridge technique. Anything can be done. The classic double row repair, the advantages over the single row is a wider contact area, but higher repair strength. The suture bridge technique, where I am using, showing that in this video, the final one, less tissue strangulation, bridging sutures give better compression footprint and less intraoperative time. This is a split pitch technique where there is no knots are there. With the concerns of the medial strangulation because of the medial knots are addressed, and the suture tendon surface pressure is reduced and better healing potential. These are all the various advances as we are getting more and more into the rotator cuff repair techniques. But when you go to the literature, frankly speaking, single row versus double row, knotted versus knotted, double row technique, transverse suture techniques, more or less, all of them are giving equal results. These are the literature support. And then a chronic rotator cuff tears you need to do. These are the possible options we have: a repair with augmentation, a superior capsular reconstruction, a balloon placement, a tendon transfer, and finally shoulder replacement as needed. Coming to repair and patch augmentations, the absolute indications are being massive cuff tear with failure to mobilize, poor tendon tissue quality, and failed previous repair with re-tear. And this is how we do regularly. And coming to superior capsular reconstruction, the principle is to reconstruct the superior capsule of the glenohumeral joint so that the stability of the joint is restored and the proximal migration of the humeral head is prevented. See, there are multiple options we have. We used to use either facial leta or a dermal allograft or peroneus longus tendon along with biceps, that is biceps supercapsular repair. Out of all, in my hands, peroneus longus tendon being autograft, strong, long tendon, it requires a simple harvesting technique and with a good autograft and good vascularity. And I personally feel it is giving good results in my hand. And that's how you can see that is one area where recently done one. That's how superior capsular reconstruction has been done using long enough biceps, long enough biceps and peroneus longus tendon, and completely bare shoulder, and that is the one that the superior capsular reconstruction has been done. Then coming to arthroscopic balloon placement, the concept is to keep a subacromial balloon spacer. It acts as a mechanical spacer between the humeral head and acromion, but the posterior and anterior cuff should be intact in such case. And preoperatively, patient should have a good movement, but with pain. In that case, it is it gives a relief of almost 1 to 1.5 years, biodegradable saline-filled implant. Then come to massive irreparable tears. The goal of this one is to restore balanced force couple and shoulder kinematics using other tendons. This is the goal of the tendon transfer and massive irreparable rotator cuff tears. Multiple tendon options are there. The common ones that are used are lower trapezius and latissimus dorsi. These are all the two common things that are used. Pec minor, and teres major also have been used. And these are all some certain things which we regularly use. So in conclusion, what I wanted to say is surgical management of the tendinopathy varies from the stage of the patient presentation, number one, and the need of the patient in that particular individual. Therefore, the surgical management should be selective and tailored to the need of the patient as needed at the time of the presentation. And we need to address in surgical management not only the tendinopathy, but the altered biomechanics of the shoulder joint because of the tendinopathy that affected. And lastly, the rehabilitation protocol post-surgery is also very, very important, as Dr. Naresh Shetty sir mentioned very nicely. And the word is orthobiologics. I being a BMAC man, there are a lot of growing importance and promising in terms of partial cuff tears in shoulder joint. And with that, I sincerely thank Dr. Alex and Dr. Santosh for giving this opportunity. Thank you.
Thank you, sir. It was an excellent presentation of what all that can be done in shoulder tendinopathy, right from the basics of creating a subacromial space to repairing and pericapsular reconstruction and augmentation of the repair. So thank you. Thanks a lot, sir. Now I think we'll move on to some of the questions which are being coming up. So I would like to ask first question to Dr. Which has come up through YouTube, and It is for Dr. Vinu. Sir, can you let us know what are the treatment durations for nutritional supplements and what results can be seen? Do you recommend doing an imaging or just it's a functional improvement we want to reassess and the pain relief which you want to reassess? So this is for Vinu, sir, if he's available, sir. So can you please answer this?
Vinu, can you hear us? Dr. Vinu?
No, he is mute.
He is muted.
He is mute. Mr. Saurav, can you call Dr. Vinu and check once? We'll go to the next question till that time.
Just
And,
doing that.
Yeah. The next question will be being asked for Dr. Naresh, sir. Sir, they're asking, is there any charge which they have asked for the patients will have to pay for the Tendocare rehabilitation program exercise thing which we can give it to them?
I don't think so.
Yes, sir. I'm very sure there is no charges for
Yes,
that.
Saurav.
It's a free thing. I
Yes,
think.
Saurav. Hello.
Dr.
Vinu's
Shankar,
come
Dr.
back.
Vinu's online.
Vinu, sir, the question for you,
Ah.
what is the duration of nutritional supplement or nutraceuticals like collagen and chondroitin sulfate and all you want to
3
give?
months or
And-
more. 3 months or more. Can you hear me? Can you hear me?
Yes, sir. Yes,
Am
sir.
I
We are hearing.
unmuted? I think I was muted. Am I unmuted?
Yes, sir.
Yes.
Yeah. I hope you can hear me. The recommended dose is 5 grams per day for a duration of 3 months or more. 3 months or more.
Okay. So 3 months or more. You want to check what are the things you usually expect to improve,
Yeah,
sir? Is it the pain?
definitely. So before starting, as soon as the patient comes, no, again, the previous presentation it has been told that no, you do all the inflammatory parameter checkup, whether you want to know whether it's a rheumatoid arthritis, you want to know it's a spondyloarthropathy, whether it's a gout, the crystal deposition, everything. I would check all those things. I will definitely get an X-ray, and the symptoms are not resolving. If it's a symptom warrants it, I would go for an imaging like an MRI also. In a skilled hands, even they can give a good ultrasound also, so good. So before that, I'll check all those things. Especially rotator cuff. Some people are not. Some of the radiologists are not very happy with the ultrasound. They want us go for a MRI. So if it's not resolving, I would definitely go for an MRI also. But unlike Achilles tendinopathy, you cannot go in and measure your thickness of the tendon with an ultrasound probe and all that. So then I would suggest they go in for the eccentric exercises along with collagen supplements with vitamin C. And this collagen supplements, they say that give about an hour or 90 minutes prior to the exercises, start of exercises, so that when you're doing exercises and this your growth factors are released already, this hydrolyzed metabolites or the amino acids are already available for you with the blood pool, and with the neovascularization, it's available at the tendon site.
Okay, sir. Okay, thank you for that answer, sir.
Thank you.
And
Thank you.
one question for Krishna, sir, now. So one of the doctors is asking, is arthroscopy a must for any surgery? Do you want to recommend it for all the surgeries, or it's just for a hydro distension you plan?
Sorry, I didn't get you the question. Sorry.
Sir, the arthrography, sir. So you are doing the arthrography.
Yeah. Arthrography is always better. Ensure that you are injecting your saline into the joint, because a proper distension itself, when we are injecting the saline into the joint properly, we can clearly see that the joint is distended and the joint moves. And therefore, orthography is mandatory. That's what I feel. As I showed very clearly, in every case, I wanted to see the torque. That is orthography.
Yeah. One thing I can add, sir, is like if the doctors are trying to give it in an OPD setting when they don't have a C-arm or an ultrasound,
Yes.
simple thing is to see the backflow. If there is a
That
good
is-
backflow, I feel that it is into the joint. If it is going easily but no backflow, then probably into the muscular area. So one of the suggestions is, but arthrography, as you said, it's a must, especially if you are not trained in ultrasound and if you don't have an ultrasound machine to guide you. Thank you.
I can add on that in the OPD, we all have fluoroscopic. Usually,
Yes, sir.
That just a minute, just it's a
Yes, sir.
matter of hardly. The point is what I wanted to tell is very simple.
Yes, sir.
Palpate the coracoid with the shoulder extended like this. Palpate the coracoid. Just go 2 centimeters lateral to the coracoid and 0.5 centimeter below. Straight you are in the joint. That's simple.
Thank you, sir. Thanks for that valuable tip of giving where anteriorly how you go, because most of them, I think they try from back and it's very tedious to go from the back. With only experience it comes.
Thanks.
Yes, sir. Thank you, sir. That was one more question there, which you want to go from anterior or posteriorly. As you said, anteriorly would be better. Thank you, sir. There are a few more questions, sir. Just a minute. On corticosteroid injections, I think it is open for all. Krishna sir, you can give your valuable input first, then Naresh sir and Vinu sir also can add. Corticosteroid injections, what is your experience and would you want to use it or you want to use PRPs now?
In shoulder, corticosteroid or PRP, both I don't use. Very rarely, if the patient is having very severe pain and medically not fit for these kind of thing, I inject the corticosteroid subacromially from posterior. That is my call. PRP, I don't inject. I am a man of BMAC, and if there is a partial cuff tear or tendinopathies, I inject BMAC into the both subacromial as well as into the joint if there is inflammation.
Naresh sir, any input from you, sir?
Yeah, I do use steroids occasionally, but most of the time I do it in case I require to manipulate the shoulder under anesthesia. So that's the time I use that. But PRP, I'm not very comfortable because I've never been really happy about its results. I mean, it's always not that I have not used it, but the results have not been so very heartwarming to really recommend it again and again. So that's how it is.
Thank you, sir. Vinu sir, your experience with
Yeah,
steroids,
I'm
sir?
here. I see. See, for the just like both my colleagues told, when there is severe pain and especially if they are not ready for a surgical procedure or intervention, I also tend to give a steroid shot, making sure it is not into the tendon. And of late, you know the recommendations. You should be using or get the help of a musculoskeletal sonologist and making sure your needle is not in the tendon. But the recent recommendation is if you are using PRP, this PRP should be given into the lesion, should be given into the lesion in the identified lesion. So definitely you need the help of a sonologist, expert sonologist, and where you have to make sure that the tip of your needle is into the. And here, just make sure the PRP is not mixed with steroids. In fact, I've seen and experienced that some of our surgeons would like to mix PRP with steroid because most of them are using leukocyte-rich PRP, which can give rise to certain undesired effects like severe pain.
Thank you, sir. So one more question to all the panelists, like, is there any special care or treatment for diabetics with tendinopathy, or does it follow the same protocol? I mean, sir, can you answer this, sir?
I think majority of the times what we, as the literature says and our clinical experience also, some of these diabetic patients develop more often the tendinopathy in the shoulder along with the tender Achilles also. And they are the people who have a tendency to progress very rapidly towards stiffness, that is adhesocapsulitis. So the protocol is the same, like we need to start with the NSAIDs that is suited to them, then go for along with the collagen peptide supplementation, then unsupervised physiotherapy, all these things. But my experience is the phases between 1, 2, 3, 4 are very rapidly progressing to them. and the quality of the tendon somehow in them is very, very bad. So those cases we need to be very careful, especially when they are following the physiotherapy. No question of, as Dr. Naresh sir mentioned very nicely, first is get the regain the complete arc of movement, then only strengthening.
Okay.
Do strengthening when the movement is not regained, we are going to damage the tendon more on the joint. Therefore, one need to be very subtle, get the arc of movement, be gentle. In there, the recovery is also very slow. And I intervene if their phase is going very rapidly into stage 3. And especially if the HbA1c is below 8, then only I do this distension. Otherwise, I don't. And definitely they will come back with that intervention. That's my personal experience. And I wanted to give this advice.
Coming to diabetes and shoulder, I think that's the only place where I become a good physician. Many a times people come with shoulder pain. That's the time I said, listen, and he doesn't have any injury or otherwise, and he comes with a shoulder pain or a stiff shoulder. I said, get your sugars done. I want to see it before I treat you. Most of the time, if you look at the story, anyone coming with shoulder, a very sedentary lifestyle, I think you must rule out diabetes. And many times I've been fortunate, I do not know, I may be an exception to the rule, fortunate to make a diagnosis of diabetes, and the patients are very happy saying you not only you're a good physician also. So that's but in diabetes, once you start an exercise therapy, always tell the patient to do it on the opposite side, because many a times in diabetes, very frequently, they tend to get it on the opposite shoulder. It's very, very important that you should tell them, because that's a hallmark of getting a full functional recovery of the shoulder. That's what it is. It's sometimes painful, sometimes takes a long time to recover, but yet it will over a period of time, if the patient is persistent, doctor is persistent, and the physiotherapy is good enough to be persistent.
Thank you for that. As most of the times we as orthopedics diagnose diabetes, as sir said, with it.
Yeah, I would, Dr. Santosh, I also would like to emphasize that, I would insist on proper glycemic control. And just like Dr. Krishna and Dr. both of them were telling, the physiotherapy should be gentle, meaning you should have a proper physiotherapy and a proper glycemic control at the same time. So I would also like to emphasize that point.
Is there any the functional like and rate of, or do you put the
Sorry, the audio was breaking.
Dr. Santosh, your audio was breaking.
Oh, sorry
Yeah.
for that. The question is, how do you monitor the progress of tendinopathy treatment? Is it any scoring method you use, or do you just assess with the range of motion, pain, and strength of the cuff muscles?
I think in one of the slides we were mentioning, SF36 is a very good, the simple 36 questions, simple format. 36, SF36 you can do. Then you can the patient stated outcomes like pain and function you can measure. Naresh sir and Krishna sir, I would like your opinion, please.
No, it's basically clinical and periodical checkup. That's it. Clinical periodical checkup, improvement in the shoulder function, decrease in the pain scores, etc. And if the patient insists, rarely we may go for ultrasound of the review ultrasound after 3 months. That's how I practice.
Yeah, I think clinical part is more important than anything else. I mean, it's always, I think this diagnostic, I think should be kept as an important tool, but not necessarily to get it across. I mean, it's unfair to the patient, unfair to our clinical acumen also.
I agree with that. In the OPD practice, it's basically you just see the movements, whether they've improved if you're documented previously, and just check whether their movement is improved. And like simple Job's test to assess the supraspinatus, was it painful and how painful is that? You can ask the patient itself, is it better or is it worsened? That is again a scoring system for us. And I usually prefer to assess them once in 3 to 4 weeks, because prior to that, you will not be able to get a good improvement score or range of motion score, sir. So that is like how I practice. And some other questions were like same thing. How many days of nutraceuticals you want to give? It's around approximately 3 months till you can say has improved or not improved. If it's not improved until 3 months, then I can think you can stop the nutraceuticals. And giving antibiotics before steroid injections. Do you practice that, sir? Naresh, sir?
No.
Always in that? No. Okay.
No, I don't do that.
Okay. Okay, sir. Some of the times.
I don't believe in that. That's not right way of doing it. But one need to be careful about looking for any kind of a reason why the patient can have an infection. But otherwise, I don't do that. I don't do that.
Okay, sir. Okay, sir. Okay, sir. And I think most of the questions are answered.
But I have one suggestion. Since they have given a link for exercises,
sir.
if the TendoCare can also give a link to assessment of the patient on a regular basis, I wouldn't be very happy about that. Patient will send me an assessment, and before he comes, I know the assessment, and I don't have to spend too much time talking to him, I guess so.
Oh, sir, actually, there are some other apps which like Rehab My Patient, which we are doing in Baptist Hospital. They give a link and there are specific YouTube exercises the YouTube also shows. But the problem with that is it's a paid one and it's very expensive to have in one of the institutes we are able to have. But for each doctor, it's difficult. And there, one of my physio told me that they can also send me they can send a assessment like what they are doing now. So that was another thing, which luckily the format should not generate, then we will not be able to see the patients.
Okay.
I think, yeah, thyroid dysfunction is also one of the reasons for tendinopathy. And it's basically a metabolic syndrome, one of the questions asked. Sometimes you see that the thyroid and sugars are normal, and it's only the dyslipidemia which has caused that tendinopathy. And that is very common nowadays. You try to look for sugars and thyroid levels, but we have seen basically a lot of cholesterol variations have caused the tendinopathy. And that also has to be addressed along with your rehab program. So if you don't address the metabolic syndrome, I don't think the tendinopathy will heal by itself. And coming down, I think Alex sir will close this down, sir. Now most of the questions are answered. There are no more questions.
Yeah, right. Thank you, Santosh. So as we conclude today's session, thank you to especially to our distinguished speakers and the moderator, bring very expert insights and a lot of practical tips, especially for our younger colleagues. And I'm sure it will be of immense value in clinical practice, in the day-to-day practice. The next webinar in this series will focus on tendinopathy around the foot and ankle, and we will share the timelines with all of you shortly. Thanks once again, Santosh, for the moderation. And once again, thank you to the PharmEd, the partners, Dr. Chandrasekhar, Jayanta, Saurav, and Anand, and also to Cataract for the support and coordination. And finally, the most important people here, the audience for joining us today. We hope that this session has enriched your knowledge and will help you translate these learnings into better care for our patients. Patients, we need to constantly keep reminding ourselves that they remain at the very center of our work as healthcare professionals. Thank you. And
thank you, sir.
Thank you. Thank you, sir.
Thank
you also
Thank
to
you,
you and
Dr.
to us.
Alex sir, Naresh sir, Krishna sir, and Dr. Santosh for organizing, and PharmEd for organizing. Thank you very much.
Thank you, everyone. Thank you, and a great night.
Yeah, thank you.
Spirits can flow.
Yeah, thank you. Good night.
Thank you, Alex sir. Thank you for the
Thanks.
Thank you, doctors.
Thank you.